My senior honors project focuses on the health disparities seen in Latino non-citizens in California. First off, I'd like to thank my mentor, Dr. Charles, for being an amazing mentor. She's taught me a lot with her experience and has been very patient throughout the process of my senior honors project. Dr. Charles is more than knowledgeable on healthcare access, as she's been the Director of Health Insurance Studies and has spent 9 years as a Senior Research Associate at the UCLA Center for Health Policy Research. I couldn't have done such an amazing job without her. Thank you again, Dr. Charles. Now I will go over what my project focuses on. For my project, I'm looking at access to healthcare for non-Latino U.S. citizens and Latino non-citizens in California. My project will focus on Latino non-citizens, but it will compare it to the non-Latino U.S. citizens as the control group. The data that I will be using will be coming from the California Healthcare Interview Survey, also known as CHIS. This is conducted by the UCLA Center for Health Policy Research, and it's administered to 20,000 households annually, and it's a phone-based survey. To be able to measure healthcare access, I look at 3 variables. The first one being number of doctor visits in the past year, the second one being delayed getting necessary care due to cost or no insurance, and then the last one is had to forego necessary care. Before delving into my own project, I was able to look at past research. This helped me come up with a hypothesis, and this helped me compare my results to what was seen in the past. What I saw in the past research by the California Health Interview Survey in 2008 was that non-citizens of both genders in the United States were having low rates of health insurance compared to citizens. Another interesting study by the UCLA Center for Health Policy Research in 2013 found a lot of disparities among undocumented immigrants, those being the highest rates of poverty and being uninsured, them having the highest rate of not having a usual source of care. They are least likely to go visit a doctor in the past year, and they are least likely to use emergency department care in the past year. In public health, the Anderson model is a model that is commonly used as a conceptual framework. It has been used since the 1960s to understand why families do or do not use healthcare services. For my project, I'll be using a modified version of the Anderson model that is specific to my study. This model will be used to understand why Latino non-citizens use or do not use healthcare services. To understand this phenomenon, the Anderson model observes categories of predisposing characteristics, enabling resources, need, and use of healthcare services. Although there's an understanding of other potential factors that could contribute to Latino non-citizens using or not using healthcare services, for time's sake, it was only the highlighted parts of this slide of predisposing characteristics and use of healthcare services that were able to be looked at. For predisposing characteristics, I looked at citizenship status and racial ethnic group, and for use of healthcare services, I used 3 different variables, the first one being doctor visits per year, the second one being delays in care due to cost or no insurance, and forgoing needed care as the last variable. After I got the data from CHIS, I was able to run it through SPSS and generate graphs. This first graph represented the first variable I looked at in measuring healthcare access. The first variable that I looked at was 0 doctor visits in the year. This means that people wrote down that they had 0 doctor visits in the whole year. For the graph, you can see that the orange solid bars are non-Latino and the striped bars are Latino. And under each of those bars is varying citizenship status of U.S. born citizen, naturalized, and non-citizen. for both non-Latino and Latino. Then there's a checkered bar at the end, and that represents the total. At the side of each bar, those are the totals for that whole group, and at the top of the bar, those are the percents for that group. Those percents can be looked at, and the bars can also be looked at to see the differences in those groups of getting 0 doctor visits, of reporting 0 doctor visits. So, in this graph, it's shown that Latino non-citizens have a higher reported amount of 0 doctor visits than non-Latino US-born citizens. If you compare that striped 29.9% to the solid 14.1%, you see that there's a huge difference. Another important thing to look at is that all of the striped bars compared to the non-Latino ones that are solid, they're higher when you look at just citizenship status. So US-born citizen for non-Latino has 14.1%, and if you look at US-born citizen of Latino, it's 21.5%, and they're all higher on the Latino side. So this means that just being Latino has a disparity right there to healthcare access, because these Latinos are reporting more doctor visits that are 0. They're getting 0 doctor visits compared to their non-Latino counterparts. For the second variable, I looked at delays in necessary care due to cost or no insurance. This just means that people are not getting the necessary care they need because they don't have the money for it or they don't have insurance. And this is called delayed care. For this graph, it was seen that Latino non-citizens have the highest reported amounts of delayed care due to cost or no insurance across the board. This is represented by the highest bar. The highest bar is a 72.5% under non-citizen Latino. This is seen in the past graph too, in the last graph, that non-citizen Latinos had the highest amounts of disparities in healthcare access. In this case, it's delays in necessary care. The other aspect to look at is the percents of non-Latino versus Latino. If you look at the corresponding ethnicities of non-Latino and Latino, Latinos have the highest percent. So just looking at Latino versus non-Latino, Latinos have the higher amounts of delayed care due to cost or no insurance than their non-Latino counterparts. Finally, the last variable I looked at was foregoing necessary care. Foregoing necessary care just means that they're not getting the care that they need. For this graph, it was seen that Latino US-born citizens have higher reported amounts of foregoing necessary care than Latino non-citizens. What this means is that the highest bar on this graph is the US-born citizen Latino. Before, the other two graphs had non-citizen Latinos as their highest bar, and that was what was hypothesized and seen in past research, but this graph is a bit different. Now, looking at the other aspect of just comparing non-Latino percents to Latino percents, it's seen that despite citizenship status, that just being Latino has the highest percent, so they're having the highest disparities in foregoing necessary care compared to the non-Latinos. To summarize the conclusions of my study, I created this chart. I have my variables, the 3 variables there, and then I have the column of highest percent. This is based on the highest bar that was seen in all 3 of the graphs. For the first 2 variables, it was Latino non-citizens, and this was hypothesized and seen in past research. The only different one was the third variable, and that was foregoing necessary care. And it was still under Latino, but it was seen that the Latino US-born citizen was the highest. Now, the last column that I have is the highest percent based on ethnicity, just looking at Latino versus non-Latino. And all 3 graphs showed that the Latino community is the one that has the highest disparities compared to non-Latino for healthcare access. This information can help healthcare planners create a more affordable and accessible healthcare system so that the healthcare access disparities seen in these vulnerable groups aren't as heavy on them. In addition, it's important to note that although my study has these conclusions, there are other demographics that could be looked at that weren't looked at in my study that could be reasons why these disparities are seen. Demographics like gender, educational attainment, income, etc. But those are things that weren't looked at but could be potential reasons. That is the end of my project. Thank you so much for listening and for looking at the results of my study. I once again want to say thank you to Dr. Perez for being an amazing director for the honors, for the university honors program. And thank you again to Dr. Charles for being an amazing mentor.